Hello everyone, Leslie Cornwell here, Midwifery Business Consultation. This next section is Neonatal Resuscitation. Objectives, the things that will be accomplished over this learning course, being able to recognize why knowing about newborn resuscitation is important, what risk factors to watch for that are higher chance of newborn resuscitation, having the skills and training equipment to be able to handle a newborn resuscitation in or out of hospital birth. Being able to follow the NRP algorithm. There's a basic one attached to the sheet, but I would highly recommend everybody get Neonatal Resuscitation Program certification and get the latest edition book that has the algorithm and details. Be able to manage newborn care after resuscitation. Newborn resuscitation, what is it? It's a series of actions used to assist the baby with breathing that's having a difficulty transitioning from the inside the mom to extrauterine life outside. It's typically because the lungs just need some assistance being opened up. But there can be more advanced, especially in the hospital setting, with risk factors, preterm labor, twins, especially really early babies. Advanced resuscitation is more important. So we're going to focus more on the out-of-hospital, low-risk, healthy moms. Statistically speaking, 10% of the babies need resuscitation and less than 1% need advanced resuscitation. That is hospital and birth center statistics, but I truly believe that out-of-hospital birth is lower risk. But either way, it's our responsibility to have the knowledge and skills to take care of those situations. Most newborns are vigorous at birth. During a water delivery, the APGARs are going to be a little slower and delayed. The baby starts crying typically when the cheeks, the trigeminal nerves, are exposed to air. So when a baby goes from water inside mother to water in the tub, they usually don't realize they are out until their face hits the air. So the APGARs are normally a little bit delayed, which is normal. So I always stress to people, when you're considering newborn resuscitation, look at the bigger picture. Even if the baby isn't immediately crying as soon as they're coming out, is there good muscle tone? Is the baby alert? Is there a heart rate above 100 from the cord? With good, strong muscle tone, the baby's getting good oxygen. The baby just doesn't know that it's out. So everybody take a slow cleansing breath and have the mom talk to the baby. That carbon dioxide from her mouth will help encourage the baby to breathe. So it may be 15, 20 seconds after birth that the baby takes its first breath, as long as everything else is reassuring, which is sometimes under different interpretation with NRP guidelines, especially in the hospital setting. So really respecting normal birth, but also if there's signs of concerns, the heart tones are less than 100, there's no respiratory effort, the muscle tone is weak, don't hesitate to resuscitate that baby. Resuscitation equipment you want to have present. Newborn warmers, traditionally in a hospital setting or a birth center that has state regulations requiring it. Most birth centers and home birth practices do not have that high tech fancy warmer. A lot of places I've been part of will use just simple things. They'll have a cookie sheet, a firm flat surface with a heating pad, towels, so then you can take it wherever the mother goes. Try to keep the cord intact as long as you can if it's giving the baby oxygen and blood flow through it. It'll just help with your resuscitation efforts. Newborn ambu bag, a stethoscope, thermometer, pulse oximeter, bulb syringe, which is rarely used anymore. LMA, typically size 1 is all you need in out of hospital setting. ET tube, if you're choosing to do advanced resuscitation, the ET tube, the CO2 detector in the ET, if you're going to do a tracheal resuscitation. I encourage an out-of-hospital setting, know your skill set and know when to call EMS and get more advanced support involved. An oxygen tank is important in any setting, and extra warm towels so that the baby can stay nice and warm during the resuscitation process. Assessment of the newborn at birth. Cord clamping, there's not a lot of research showing and I wish there were more, how important it is to keep the cord intact. I think the newer NRP guidelines are going to really stress having equipment that's more at the hospital bedside versus cutting the cord and taking the baby over to the warmer. But if there's anything we can do to keep the cord intact, if it's still giving the baby blood flow and oxygen during the resuscitation process, will really help. Severely compromised newborns are more likely to need resuscitation measures over the delayed cord clamping. So just know equipment you have, where the layout is, and how you can, the obvious most important thing is getting ventilation and the airway adequate. So if you can't do that with the cord being intact, you have to do the best you can with what you have. Initial assessment, an APGAR score done at 1 minute and 5 minutes. The 1 minute they're finding more and more doesn't have so much to do with long-term neurological outcomes. It's more how stressed was the baby before the birth process. So especially in a hospital in the C-section litigation, those APGAR scores, the acidosis level from the cord blood is really important, but the one that's for long-term brain function has to do with a 5-minute APGAR. So our goal would be to get that above 7 at 5 minutes. Sometimes the kids are just a little stunned when they come out. As long as they respond rather quickly, then you know long-term they're going to be good. It's rare to do a 10-minute APGAR. If the APGAR at 5 minutes is less than 6 and you're doing a resuscitation, every 5 minutes continue doing the APGARs. An APGAR score has to do with a 10-point score from Virginia. APGAR created it. It has to do with respiration rate, the baby's crying, the reflexes, irritability, the heart rate, and the color of the baby, comparing the chest to the arms, and then the muscle tone. Goes into details what that score is. So most of out-of-hospital births are going to be 8 and 9, 9 and 10. You're going to have most of the time pretty normal, healthy mamas. But if you're ever curious where the APGAR score is coming from, has to do with a 0, 1, 2 score for each of these sections. So a heart rate that's not even present is a 0. If it's less than 100, if it's above 100, then those are the differentiating factors. If there's any respiratory effort, it's pretty common when the baby is stressed out to not having any breathing respiratory effort by 1 minute, and that's where you're trying to get the ventilation and get that baby to transition. If they're having a weak or a gasping, it's just a score of 1. But our goal is most of the babies are going to have a heart rate above 100 by 1 minute. They're going to have a good strong cry, good strong muscle tone. They're going to be pink. Mostly their chest. You're not going to get pink all over, rarely, until the first couple days after life. So if the baby is usually off for a score, it's typically the hands and feet not being pink yet, because that's pretty rare unless they come out screaming and get good circulation right away. So APGAR scores achieve an 8 to 10 by 90% of the babies. There's not anything extra you have to do for these kiddos. You just get them skin to skin with their mother, try to keep a de-stressed environment, lights dimmed, calm environment, just especially if you're doing a water birth. Once they're above the water, you just make sure that the baby stays above the water. There's not anything. It's old school model to do the oral and nasal suctioning of the baby with a bulb syringe. Let the baby drain that out, doing skin to skin and gravity, taking that out of the mouth as long as it's not causing any stress. Keeping a good temperature. So the advantage we have is warm blankets, skin to skin with mom or partner really keeps that baby nice and warm. The hat, there's no evidence to support the hat will actually improve the warmth of the baby. So some midwives will do a hat, some won't. But the biggest thing is skin to skin, making sure the room is warm, the tub temperature is warm, and the baby is getting dry. APGAR score of 5 to 7 at more the 5-minute point is mild asphyxiation just before the birth. So responding quickly with stimulation, blow by oxygen. If the baby isn't breathing well, you definitely want to do PPV and ventilate the lungs. APGAR scores of 3 to 4. A baby is pretty significantly depressed. You need to initiate pretty aggressive newborn resuscitation at that point. Make sure that the heart rate is responding with adequate ventilation. Reposition the neck, get the lungs with your stethoscope auscultated and make sure that the air you're putting in with a PPV is adequately getting into the lungs. If the color is blue, there's poor respiratory effort, don't even hesitate, just start newborn resuscitation. Don't try to do stimulation. Apgar 0 to 2, that's severely asphyxiated. It's typically early preterm, high risk deliveries. It's extremely rare in out of hospital setting, but I wouldn't even hesitate to be calling, as soon as you do a significant resuscitation, calling EMS, starting to get transport to the hospital ready in place for that situation. So normal newborn vital signs: temperature 97 to 99, axillary. It's not recommended to do rectal temperatures on babies anymore. A pulse between 120 to 160. If I'm getting 100, 110 and everything else is perfect, I don't stress about it, especially if the baby was having a baseline of closer to 110, 115 after it was born. So if there is good color in the chest, the muscle tone is strong, the baby is alert, crying, and the heart rate is the only thing that's a little bit low. If it's under 100 and all the rest is perfect, I call the pediatrician just to make sure there's no underlying arrhythmia. If in a few hours it doesn't self-resolve. Respiratory breathing rates 40 to 60, and that's what you're focusing on when you're doing your PPV measures for the baby. On the other side of this is the algorithm from the newest guidelines with NRP. Get yourself an NRP book, take the course, the training. If you're doing any out of hospital births or births in general, should have 2 attendants that are NRP certified, so the birth assistant and the midwife. Which babies need to be resuscitated? There's questions you ask prenatally during the labor process. Is this term delivery? We make a lot of assumptions with a home birth that they should be between 37 weeks to 42 weeks. Is when the baby comes out, is the baby crying? Does it have good muscle tone? If the heart rate's above 100 and the baby hasn't instantly cried and the muscle tone is good, just give the baby a few seconds. Don't just quickly go to the extreme. But if the tone is weaker and the baby's having trouble breathing, don't even hesitate trying to get the heart rate. I can tell you it's going to be low. If any of these questions, if you answer yes for all 3 questions, the baby does not need to be resuscitated, should just stay skin to skin with their mother. If you answer no, you need to look at the bigger situation. If the heart rate's less than 100, the muscle tone is weaker, the baby's not attempting to cry, ventilate, ventilate, ventilate. The chest compressions are the rare that's farther down in the NRP algorithm. Most of the time, you just need to get a good seal with the bag and give that for 15-30 seconds to get the baby's alveoli to open and get them to respond to being outside this world. It's usually all you need to do in an out-of-hospital setting. Epinephrine medications, intubation, volume expansion are more advanced NRP standards that I wouldn't expect home birth midwives to have supplies for, birth centers have supplies for. The baby should be transferred and taken care of in a hospital with those advanced skills needed. The golden minute, that first minute, there's a lot happening in a short amount of time. The midwife is keeping an eye on the mom's vaginal bleeding. The baby came out. There's a quick assessment done and closely watching the baby. Sometimes they come out and cry and have good muscle tone right away, and sometimes they just need a little bit of help. So seeing what that respiratory effort looks like, what is the heart rate? Our goal would be using a stethoscope to listen over the baby's chest, but you can use the cord and do pulsation if you have those skills. So for a heart rate, just do 6 seconds. What's the number you're getting from the cord or from the stethoscope, and then times it by 10 is the baby's heart rate. So newborn assessment steps. Every 30 seconds with the NRP guidelines, we're going to check the heart rate and make sure our resuscitation efforts are working. Anytime you're providing resuscitation, the heart rate should be improving, and our goal is to get it above 100. If we are attempting resuscitation efforts, repositioning the neck, not getting good airway exchange, the heart rate's not going to continue to increase. A pulse oximetry is a great option if you're in the hospital setting and you have numerous resources helping to take care of the baby. Typically in an out-of-hospital setting, there's just 2 people present, so you want to make higher priorities of your limited staff. The highest is going to be ventilating and checking the heart rate and the lungs to make sure that you're getting adequate ventilation. Usually a pulse ox is nice to place on after things get a little more settled and you want to see what the oxygen level is and keep a close eye on the baby's heart rate without using a stethoscope. If you have a significant resuscitation, there's not going to be good circulation to the hands and feet, so the pulse ox isn't even going to work at that point. Anticipation of a resuscitation need, training your staff, keeping up with your competencies, anticipating what are the risk factors for a newborn resuscitation, making sure you have all the proper equipment for your setting, that it all works well. You check your inventory before a birth. You accurately are evaluating the baby and making the decision promptly, does this baby need resuscitation or not? The big things to focus on: what's the heart rate when the baby comes out? What's the muscle tone? What's the breathing like? And then make the decision from there. The majority of babies needing newborn resuscitation can be determined prior to delivery, especially in a hospital setting. Really early babies, thick meconium, aspiration, really stressed out heart rate pattern, inductions for preeclampsia, diabetes. We have the advantage being in an out-of-hospital setting that most of our women are pretty low risk and healthy, but you can get those surprises of a rare placenta abruption, a cord, prolapsed cord, a colt cord, things you just don't anticipate to stress the baby out towards the end of delivery. So sometimes newborn resuscitations do happen when you don't expect it, but most of the time there's anticipatory risk factors present. Initial steps: always provide the baby with warmth. In a hospital setting, they have a radiant heat source. And out of hospital, we usually use the mother as the skin-to-skin warmth site. We can use a cookie sheet, a firm flat surface with a heating pad and towels. Just a warm flat surface is what you're looking for. If you need to resuscitate the baby, it's hard to do that with the mom holding the baby because getting that neck and the airway in a good position. So positioning the head, stiffening it. So this is usually done with a flat, firm surface, clearing the airway if necessary, if there's fluid present, but usually you just want to ventilate, dry the baby, and stimulate them to breathe. If it's a mild asphyxiation, usually stimulating does it, but if their heart rate's below 100 and their muscle tone's weak, you can stimulate all day long, but you need to implement PPV at that point, the positive pressure ventilation. The baby is dried, placed skin to skin with a mother, and covered with a linen to maintain the temperature. This is typically those healthy babies, no complications, just keeping a close eye on their color. Even after you do a simple resuscitation, as long as it took you just that 30 seconds to get them to open their alveoli, I don't stress so much about the post-resuscitation care, keeping an eye on blood sugars, keeping an eye on the baby closely, but more the advanced resuscitation where it took 2-3 minutes of pretty significant resuscitation measures. I watched the baby closely after birth. Temperature control. Sometimes we're so focused on the airway, the color, the heart rate that we forget about keeping the baby nice and warm because there's only so much our bodies and our minds can process at once. So making sure you have adequate supply of warm towels, getting the baby skin to skin with mother as soon as possible, checking the temperature in that post-resuscitation to make sure the baby doesn't get too cold. In the other direction, you don't want them to get too hot if you have the heating pad too warm. So just keep an eye on the baby. Low temperatures increase the metabolic demands and they'll lower the baby's blood sugar. So frequent feedings are really important after a pretty significant resuscitation to help prevent the baby baby from being too cold. Things to check, reasons why you would check a blood sugar is if there's signs and symptoms of hypoglycemia. So the baby is jittery, the baby has that lower temperature, the baby's not nursing the greatest. You may have to make some sugar water. If there's donor milk options, if there's other food sources available to get some calories in the baby a little bit while the colostrum is kicking in. Suctioning the airway, it should be avoided with routine newborn care. That's a newer guideline, so there's a lot of nurses and care providers still doing suctioning routinely. It causes a lot of damage. It can cause a vagal response to the back of the throat. And breastfeeding, there's a lot of studies with it just doesn't do as well. The babies don't do as well with breastfeeding because their first external response to this world is a plastic, firm suction being put in their mouth aggressively. And so we just want to be careful and cognizant of the baby as long as they're normal and healthy. If you're doing a resuscitation, especially with PPV, and there's a lot of fluid in the airway mouth, suction the mouth first and then suction the nose to get some of that extra fluid out. Especially with fast deliveries, their lungs don't get a chance to get squeezed much because we don't want to just be pushing that fluid back into the lungs. When meconium is present in a hospital setting, nationally, we can deliver thin meconium at home, but if it's thick meconium, we want to get them to the hospital setting. Those little pieces, it used to be with NRP that we would suction at the perineum, then we would routinely suction, we try not to stimulate. They're finding that the risk of meconium aspiration syndrome, it's because of the meconium already in the lungs, not what's in that throat that we're trying to suction out. So it's really important that if you have meconium stained fluid, especially thicker, to transfer to the hospital, because the baby's going to be fine inside the mom. But when they come out, some babies have a really hard time with those little pieces of meconium blocking their alveoli and making it difficult for them to breathe. So those are one of those risk factors nationally. If there's thick meconium, and as long as birth isn't imminent, just transfer to the hospital if you can. So PPV, positive pressure ventilation, if the baby is gasping, if it's not breathing, the muscle tone is weaker, the heart rate's less than 100, don't even hesitate to try to stimulate. Just instantly get your ambu bag and open up the lungs for the baby. And being careful, babies have little lungs, so the bag, you don't have to squeeze it much. It's not like an adult. So when you do BLS training, NRP is a very different, the rate and timing and depth of the chest compressions and the use of the ambu bag is very different. We don't want to give the babies a pneumothorax and put too much air quickly into their lungs. The primary reason for adequate ventilation is to improve the heart rate. As soon as we get adequate ventilation, we get the lungs to start opening up, the heart rate improves, and the baby is more likely to take a breath on its own. The chest wall should be moving, so you know that you're getting good, adequate transfer of oxygen to the lungs. And if the heart rate's not improving, that's another reason for you to say, I need to evaluate listening with my stethoscope. Is my ventilation really getting the lungs open for the baby? So the goal is to have 40 to 60 breaths per minute and to get the heart rate above 100. So you don't have to go farther down the NRP algorithm with more advanced resuscitation measures. So a laryngeal mass, some out-of-hospital midwives will have this, some don't. If there's an unknown cleft palate, it's nice to have other options to get a good seal to the back of the throat, because sometimes with a bag in those rare situations, it's hard, but it is an additional skill and training to be able to use one. So talk with your midwifery team if they have LMAs and the training you would need to use one of these. Cardiac massage, I would consider that more advanced resuscitation. If you're getting to that point, honestly, if it's past 30 to 60 seconds and your simple PPV has not made the baby spontaneously cry and you're getting to the next levels, I'd be calling EMS right away. You can easily cancel them, but when every minute matters and you don't know the distance of how far away they'll get there and the distance to the hospital, you have to think of minutes matters for these babies and their long-term brain development. So the rescuers should include that the assisted ventilation is being provided in conjunction with the chest compressions. So this is done once that heart rate gets below 60, even though you've done adequate PPV with oxygen for at least 30 seconds. Chest compressions are likely to compete with the effective ventilation. So you guys are going to work as a team and count and take turns, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. Get some sort of pattern together and practice it with clear communication. The compression should be delivered in the lower third of the sternum to the depth of 1/3 of the AP diameter. So we're not going real deep and hard. Typically, it's the lungs getting open. It's not so much, their heart rate is faster than an adult, so you have to remember that, but they're little and you don't want to be, the pressure you'd put on an adult is a lot more than a child. So 2-finger technique is a compression of 2 thumbs with a finger encircling the chest and supporting the back. Compression with 2 fingers with a second hand supporting the back is another option. So 2 thumb encircling here is the example. This is the more common one I'm used to seeing, just because for long term our thumbs have a little more strength than just pointing our 2 index fingers, our first 2 fingers. But either one is acceptable. And the maximize the delivery of the ventilations should be 90 compressions to 30 breaths. Respirations, oxygen, and the heart rate should be assessed periodically, about every 30 seconds, to make sure that the efforts you're doing are getting the heart rate up. Once you're consistently below 60, that's when there's going to be the medications, there's going to be talk of a UVC line, there's going to be talk of fluids and trachea intubation, like pretty significant advanced resuscitation. And so I'm hoping in an out-of-hospital setting, we've already been transported and getting the EMS involved by the point of needing that. Avoid interruptions of the compressions. They will compromise the artificial maintenance of the systemic perfusion and maintaining the blood flow throughout the baby. So post-resuscitation care, which most of the time in an out-of-hospital setting, there's going to be rare times you're surprised with a resuscitation. It's going to be minimally needed, just that PPV, ambu bag, getting the lungs open. But if you've had a significant resuscitation, talk with the families. Is this a good baby that should be transferred to the hospital to keep a closer eye on, or does the family want to stay home and the midwife stay longer and keep an eye on the baby? Because the baby went through a lot of stress, so they're going to burn through calories. They're going to need to be watched very closely for their heart rate, their lungs, their breathing efforts. You want to keep a close eye on these babies for the first few hours after a resuscitation. So the big thing with a stressed out baby, they burn through a lot of calories. They're going to be burning through. You want to make sure there's frequent feedings, that they're not having trouble breathing while they're feeding. What is their blood sugar? I usually not a hospital setting wouldn't check their blood sugar unless the signs and symptoms of hypoglycemia were present. And then talk about options. These are more hospital recommendations of concentration of blood sugar and how to give an IV versus out of hospital. We usually do sugar, water, reassess in 30 minutes, try to get them to feed as often as possible, get the mom to express some colostrum to put in the baby's mouth. Guidelines for withholding and discontinuing resuscitation. It's a very difficult discussion to have. There's a lot of ethics behind who would you resuscitate and when would you stop resuscitating. I know it says in here physician, but it's the provider's experience and desires to the patient. And in making the decision, the provider must consider, there's a lot to think about in a short amount of time. If you're doing out of hospital births and there wasn't a 20-week anatomy scan and the baby comes out with anencephaly, comes out with something pretty significant that's incompatible with life, that's a tough decision to be making. Like, okay, this baby has no chance of living based on these malformations, or you're attempting resuscitation efforts and it's not working based on an undiagnosed cardiac defect that is not going to be compatible with life, but you don't know at this moment. So it's a very difficult decision. It's hard for the providers on the moment because you want to do everything you can, but there's some babies we just can't say. So withholding resuscitation, if you've been trying for a minimum of 10 minutes and you're not getting a heart rate, you're not getting any response, that's when that discussion would occur about stopping resuscitation. It's very difficult. It's a hard one to have. It's hard for the parents. It's hard for the care providers because we want a good outcome for mom and baby. So as we talked about already, if there's no heart rate and all the resuscitation efforts have been tried for at least 10 minutes, that's when that discussion would be about discontinuing resuscitative efforts. Very, very hard discussion to have with families. So the big things I want to stress with everybody with newborn resuscitation, out of hospitals, we have a huge responsibility to keep our skills up, keep our training, have our appropriate equipment, make sure we're delivering low-risk healthy women at home, and we're being proactive to training our staff and giving moms and babies the best chance they can of a start to life. Most of the time, babies are going to do great. They're going to come out, they're going to cry, you're going to just be there for supportive measures. But we always have to be on our guard that if this baby does need some help with breathing, with underlying resuscitation measures, you have to know the NRP algorithm by heart. You have to have the proper equipment. You have to have the proper skills and training because babies really need that oxygen. They need to be able to have care providers that can help with that transition. So I really appreciate everybody doing this course, and we look forward to seeing you at more.